Infant feeding and nutrition part 2. In my first segment under this topic, I have discussed about infant feeding during the first 6 months of life and topics such as breastfeeding, formula feeds, supplementation was covered in that topic. In this second lecture regarding infant nutrition and feeding, we will see how complementary feeds are introduced and how infant nutrition and feeding should continue beyond the first 6 months of life. Now, breastfeeding is continued up to 6 months according to WHO standards, but after 6 months, we need to introduce other food types. So, this process of introducing foods beyond infancy or beyond 6 months is called complementary feeding. And during complementary feeding, it is a process where you start to introduce other foods, especially semi-solid foods, when breast milk alone is no longer sufficient to meet the nutritional requirements of the infants. So this transition from exclusive breastfeeding to family foods typically covers the period from 6 months to 24 months of age. So this period is called complementary feeding period. When to start complementary feeding? According to WHO standards, the ideal time is 6 months, but it can also be started earlier, say by about 5 months, or sometimes even earlier than that by about 4 months of age, if there are conditions which are mentioned below. So if a child is gaining weight too much or too slow with exclusive breastfeeding, then you can introduce complementary feeds early. If a child is growing ideally, then you can introduce complementary feeding by 6 months. But if a child is growing too much or too low, you have to introduce complementary feeds early to regularize the weight gain. If a child is having severe reflux or severe milk intolerance, then there is no point waiting until 6 months. You can start feeding earlier. The third criteria is if a mother is working and having difficulty in expressing breast milk. Rather than adding formula feeds, it's better to start early complementary feeds. So there are some important rules of complementary feeds. These are not real rules. That's why I have put them within brackets. These are good rules if you can follow them. So there are 4 main rules. The complementary feeds should be timely, adequate, safe and appropriate. Timely means it should be started at correct time, which matches the child's needs. It should be adequate in nutrition to meet the required demand. It should be prepared in a hygienic manner, therefore safe for the child, and appropriate. This is very important. Complementary feeds become good feeds for the child only if the taste, texture and contents match the child's ability to consume. Right? So for example, you can't give solid foods for a child who is only 7 months old, because he won't be able to bite on it, because that means the texture is wrong. Or you can't continue to give liquid based foods even to a child by say about 1.5 years, because the child will not get energy dense foods just by depending on the liquid food. So the texture, taste and content should change over time with the growth of the child. Problems encountered during complementary feeds mainly are malnutrition. Malnutrition means either undernutrition or overnutrition. Allergies tend to set in when complementary feeds are introduced. Foodborne diseases, again, if you are not preparing the complementary feeds hygienically, you can get foodborne disease. Same way, you can have food intolerance. Food intolerance is where certain foods the child can't tolerate well. But most of the time, with age, the children who have food intolerance, with age they tend to grow out of it. Poor eating and poor feeding habits. Poor eating habits by the child and poor feeding habits by parents are also common during complementary feeds. Then what are the benefits of continuing breastfeeds during complementary feed? Now, just because you start complementary feeds, you are not advising the mother to stop breastfeeding, because she has to continue, because breastfeeding still will be a good source of fat and vitamins. During illness, the child will not be having an appetite to eat. So, during illness, breastfeeding will continue to provide nutrition. And breastfeeding will prolong the postpartum amenorrhea, which is a natural contraception, which will allow to spacing the births. But remember, excessive breastfeeding beyond 12 months can lead to failure to thrive, because after 12 months the child should mainly eat solid based diets which are energy rich. But if you continue to breastfeed beyond 12 months, continue to breastfeed excessively, breast milk will not be enough to meet the demands of the child, and breast milk will occupy the space in the GIT which should be occupied by solid foods. So what happens is breast milk will replace the solid foods if the child is over dependent on the breast milk. Therefore, those type of children will tend to fail to thrive. But there are some exceptions. In children living in this type of environment, especially in countries with so much poverty, continuing breast milk can be life-saving. Okay. But in a child who is living in a more in an environment where there are enough facilities available, such as this, breastfeeding can lead to a child who will appear like this. Continuous excessive breastfeeding will lead to malnutrition, because this child obviously is living in an environment where there is enough food, but he is not getting the food because he is over dependent on breast milk. And the same way, breastfeeding beyond 2 years, you have to be very careful, because sometimes breastfeeding too much, like say breastfeeding until about 5 years or 6 years, may not be very appropriate, even if the mother and child can afford to do it. There are important guides to complementary feeding, which I will go through one by one. First, you have to be very patient and starts the feed slowly. The mother should never force feed the child, because forced feeding will damage the bond between the mother and baby. So therefore, the mother should be very patient and introduce feed slowly. If a certain item is refused, you can change the taste, texture and combine with other foods and try to reintroduce it to the child. There should be minimum distraction during feeding. You should not be showing distractive objects to the child while feeding, because the child should enjoy the texture and the taste and whatever the type of food the child is eating. It's better to feed together with other family members rather than having a separate time for the child, because otherwise the child will not learn the concept of family feeding. And always maintain eye contact and talk to the child while feeding, because feeding time is a time of showing love, not anger. Because most of the time in our community, feeding time has become a war between mother and child, so we should always try to avoid that happening. So this is an ideal feeding habit shown by both children and adults. They are enjoying their food, they are eating by themselves, and eating is done as a family event. This is definitely force feeding. This child is not enjoying feeding at all. So this type of behavior should not be encouraged. Right, now we will see what is the energy requirement in a child. In a child beyond 6 months, these are the energy requirement according to different age groups. So 6 to 8 months you need kilocalories, total kilocalorie of 600 per day. By 9 to 11 it goes up slightly to 700 kilocalories, and by 1 to 2 years 900 kilocalories. The calories given within the brackets is the calorie amount which should be supplied by the complementary feeds. So for example, 6 to 8 month child, out of 600 kilocalories of daily requirement, 200 should come from complementary feeds. The rest of the 400 should come from breast. But likewise, when it comes to 1 to 2 years, out of 900 total kilocalories, 550 will be coming from complementary, only 400 will be coming from the breast milk. So with age, the calories supplied by the breast milk will go down slowly. The consistency of food to meet this energy demand. Children who are between 6 to 8 should be introduced pureed or mashed foods. Pureed or mashed foods in Sinhalas, we call them matagapu cam. Matagapu cam. This is mashed foods, not smashed. A lot of medical students mention smashed foods. Smash means poluwe gahana food. Those things we don't give to children. 8 to 11 months we introduce finger foods. Finger foods means food particles which can be held by the child's finger, like a piece of carrot or piece of banana. Those things are very important because by 8 to 11 months the child will have pincer grasp and he should be able to pick up food and put into his mouth. So chewable food should be introduced during this period. By 12 months we can give our normal family foods. If chewable foods are delayed beyond 10 months, then definitely future feeding problems will occur. Then ideal foods to meet the energy nutrient requirement, rice or other cereal based main meals are important, but it's mainly, it should not solely be rice. Sometimes parents think rice is must for all 3 meals, but no, any other cereal is also acceptable. Introduce foods of animal origin and pulses early because they will be of good sources of iron and protein. By adding 1 to 2 teaspoons of coconut milk or oil or a fat spread like butter to main meals will improve the taste, texture and energy of the food. But more importantly, by adding oils, you are increasing the palatability. If you introduce too less fat, it will reduce brain development of the child and cause failure to thrive. But on the other hand, if you introduce too much fat, the child will have obesity and future serious disease risk. Add 1 or more of liver, pumpkin, carrot, sweet potato or egg yolk daily because these are all good sources of vitamin A. And it's better to introduce a locally available fruit daily. Yogurt, curd, cereals or fruits can be given as snacks. But remember, when you give yogurt, it's better to give stirred yogurt rather than set yogurt. A little bit of yogurt. Set yogurt contains a lot of trans fats. Trans fats are artificial fats which are made during processing of foods, and trans fats are dangerous to the cardiovascular health. But stirred yogurt contains only minimum amount of trans fat. Therefore, stirred yogurt is better than set yogurt. The foods to avoid during complementary feeding is mainly high sugar and salt containing foods like biscuits, cola drinks and commercial juices. Why? Because children can develop extra craving for sugar and salt later. So if you get diabetes or hypertension, it will be very difficult to cut down the sugary foods or salty foods. Sugary foods also increase dental caries and obesity. And high sugar foods lead to reduced intake of other nutritious foods. The recommended intake of food particles, cereals, you have to have 2 to 3 servings by 6 to 9 months and 3 to 4 servings by 9 to 12 months. Like that, for each milk product, there is a recommended serving. Now, what is a serving? One serving means for items like cooked cereals, vegetables, pulses and milk. For cooked cereals, vegetables, pulses and milk, one serving means 1 teacup of 200 ml. For bread, one serving is one slice of bread. Now, bread can be cut into several slices depending on the person who is cutting. What I am talking about as one slice is if a bread is cut into 9 slices. So, out of the 9, one slice will be one serving. For protein containing foods like fish and meat, one serving means 30 grams of cooked fish or cooked meat. Then nutrition values of common foods. You need to know the nutrition values of some common foods, but not each and every food item in the whole universe. So these are some of the food items which you can try to remember. It's better to remember, but it's not a must to remember. So rice, noodles, bread. So for example, rice, cooked rice, one portion is 180 kilocalories and one portion will contains 4 grams of protein. Noodles, because it's mainly water based, the energy density is less. You see, rice compared to rice, noodles which has more water, it has less energy. Bread, one slice is 90 kilocalories. Cream crackers, 4 cream crackers, 100 kilos. Banana, one banana, depending on what banana, it can be 70 to 150. So small bananas like Suandel and Nambul 70, but the bigger guys like Amban and Nanamalu, it will be 150. Apple, again, roughly average size apple can be 70 kilocalories. Avocado, 300 kilocalories. So if you can give avocado to children, it will provide more energy better than bananas and apple. These are again some common food items. Okay, you can go through them. Try to remember at least a rough value, but it's not a must to remember each and every item. But important, remember, oil 5 ml will give 40 kilocalories. So just by adding 1 teaspoon, you are giving 40 kilocalories of energy. Nutritional supplements during infancy. I'm talking about the period beyond 6 months. Multiple micronutrient supplements or MMN is supplied to children at 6 months, 12 months and 18 months by the government. It's given for 2 consecutive months at each age limit. So 6 months means 6 to 8 months. 12 months means 12 to 14, like that, 18 to 20. It's given to all children, not only for undernourished, given for every child. And it's given as a sachet. And it's given as 1 sachet a day mixed with the food. It is not water soluble, so it should be remembered that this sachet should be mixed only with food, not with water. And these sachets contain vitamin A, B, C, D, folate, and then the minerals of iron, zinc, selenium, copper, and iodine. So this is a multiple micronutrient sachet which the mother is introduced into the food, directly to the food, not dissolved in water. Triposha can be given to children but not for all children. It is given to children who are having moderate undernourishment. So moderate undernourishment means if the weight for age is below 2 standard deviation, or if the weight for height is between -2 standard deviation and -3 st, or if there is a growth faltering for more than 3 months. So usually the midwife will issue 2 packets, each 750 grams per month, and the daily serving is 50 grams. 50 grams will give 200 kilocalories, 10 grams of protein and 4 grams of fat. And triposha is made from maize, soya, full cream, powder and vitamins. Vitamin A megadose supplementation is another supplementation program which is given to both the child and mother. For postpartum mothers, 200,000 international units are given orally. For a child, it's the half dose which is given, 1000 international units. So first dose given at 6 months, thereafter every 6 months the dose is repeated till 5 years of age. And later on you can give 2 doses at grade 4 and grade 7. Now we go to the last topic of this lecture, malnutrition. So if the nutrition received by a child is not enough or too much, you will end up with two types of mal. Mal is not only undernutrition but also overnutrition. So these are the two types of malnutrition which you can see in our society. Malnourishment grading is given in, there are several grades, but I am going to talk about the undernourishment grades only. Overnourishment or obesity and overweight problems will be discussed by Dr. Vasana Kiridena in a different lecture. So undernourishment, there are two grades, moderate acute malnutrition, or you call it MAM, or the other one is severe acute malnutrition, which you call as SAM. So MAM, or moderate acute malnutrition. Remember, this is not chronic long-term malnutrition. We are talking about acute malnutrition. So MAM means weight for height between -2 to -3 st, or the mid-upper arm circumference is between 115 to 125 in children. This is only applicable to children between 6 months to 5 years. Severe acute malnutrition is weight for height well below -3 st or the mid upper arm circumference below 115 centimeters. How do you manage MAM? First, you have to use energy dense locally available foods and try to increase the energy content of the diet. You have to treat infections early, because if the infections carry on for a long time, it will worsen the malnutrition. You have to improve hygiene in food preparation to avoid foodborne diseases, which will again worsen the malnutrition. Food supplementation is necessary, and for children with MAM, Triposha program should be introduced. Vitamins and minerals are also supplemented, and parents are educated on diet. This is how you manage MAM. So moderate acute malnutrition can be managed at clinic settings. You don't need to admit the child. But severe acute malnutrition management is different. It differs according to clinical presentation of malnutrition. In severe acute malnutrition, there are two clinical variants which will occur. One is called marasmus. Marasmus is a word derived from the Greek meaning wasting, and it represents an adaptive state for prolonged protein and energy malnutrition. So there is low intake of energy, insufficient for body's demands. The body fat stores are used first. I'm sorry, you can't see this word, but then what happens is, once the fat stores are used, the muscles will be used. So finally, in these children, they will be left with only skin and bone. So these are children who have undergone a prolonged period of low intake of energy. Therefore, the body's natural energy sources, which is fat and muscles, are used to produce energy. That is why we call it an adaptive state. Clinical features of marasmus is a thin and wasted appearing child who is stunted, and because the fat is being used, the child will have no cheek fat in his face, and the face will look like of an old man. He will be very apathetic, irritable, anorexia, and having poor hair growth. So this is a typical child with marasmus. You can see it's only skin and bone. You can't see fat tissue at all. Muscles are also wasted. The face looks like of an old man because all the fat is being used to produce energy and hair growth is minimum. The second variant is called kwashiorkor. Kwashiorkor is a condition which is the name is derived from the language of Ghana. The meaning of kwashiorkor is the sickness the baby gets when the new baby comes. So we will see what this means. It is a condition where very low intake of protein, which happens over a long time. So in this type of children living in countries like Ghana and Ethiopia, their main protein source is breast milk. But when another baby is born, the new baby will get the breast milk. The old baby will not get any breast milk. Therefore, the protein source will be lost and he will go into a state of prolonged protein malnutrition. This condition, not like marasmus, represent a maladaptive state because during starvation in children with kwashiorkor, protein stores are utilized and production of proteins and amino acids will be poor. The fat which should be utilized, like in marasmus, is not properly utilized in kwashiorkor. So therefore what happens is sometimes the fat is maldistributed to the liver, causing fatty liver. So in marasmus, fat is used for energy production. Therefore that's why we call it an adaptive state. In kwashiorkor, proteins are more used than fats, and the fats which can be used for energy production is unnecessarily stored in the liver, causing fatty liver. So that is why we call it maladaptive. The body has not adapted properly for this malnutrition status. So the clinical features, because of severe protein deficiency, there will be the child will have edema, swollen belly or pot belly, hepatomegaly due to the fatty liver. Because of the edema, the child's weight may be falsely elevated. There are skin manifestations of kwashiorkor. One is called flaky paint dermatitis. That means dark cracked skin with pale skin in between the cracks. This is again due to the lack of proteins in the skin. The hair will be depigmented with brown and red hair. When there is intermittent malnutrition, you can see flag sign. That means pale and dark bands in the hair. So during periods of severe malnutrition, hair will become pale. But when the malnutrition becomes less, the hair will become dark. The hair will be very dry, brittle, thin and lustreless. There will be fissured or ridged nails as well. So this is a typical child with kwashiorkor because all these three kids have lack of proteins causing this pot belly or ascites and edema, and all these three babies are looking at the fellow who caused kwashiorkor in them. So all these three are not getting breast milk because of the new baby who is now depending on breast milk. So management of SAM, how are you going to manage SAM? I'm talking about severe acute malnutrition, not any other SAMs. So any child with SAM who is showing the following features should be admitted and treated. Now MAM we don't admit, we usually manage at clinic levels, but SAM we have to admit if the child has severe loss of appetite, bilateral severe pitting edema, there is severe vomiting, lethargy and inactivity, or if the child is having convulsions. Management during the acute period is divided into three phases. Phase 1 is the first few days where you manage medical complications and stabilize the child. So first few days we are not going to concentrate on the food, but we will be concentrating on treating complications and stabilizing the child. Now these are the 5 complications which can even kill a baby. So we have to quickly treat these 5 conditions: hypoglycemia, hypothermia, infections, electrolyte imbalance and dehydration. In phase 2, now we have stabilized the child in phase 1. In phase 2, we concentrate on feeding. So we call this therapeutic feeding period. There we are going to usually introduce foods of or foods which are easy to digest and also provide a lot of energy. So one ideal food is ready to use therapeutic foods or RUTF. Ready to use therapeutic foods are foods which are prepared commercially with high energy values, which are easily digestible by a child who is having severe acute malnutrition. There are 2 types of RUTF. One is liquid based RUTF, which we use initially, and these liquid based foods are made from milk powder, oils, vitamins and minerals. There are several formulas called F75 and F100. It's very easy to remember. F75 means 75 kilocalories per 100 ml. F100 is 100 kilocalories per 100 ml. So we usually start giving 75 and then increasing gradually to 100 to 130 kilocalories per day. Once the child is able to consume liquid based foods, we gradually change to solid foods and solid ready to use therapeutic foods like the commonly available biscuit in our hospital, BP100 biscuit. BP100 biscuit means one biscuit contains 300 kilocalories. Now one biscuit is, see, this is a biscuit and it is divided into 2 parts, or we call them tablet. So this is a tablet. So one biscuit has 2 tablets. One tablet is 150 kilocalories. So 2 tablets or one biscuit is 300 kilocalories. Now management goes to phase 3, where we rehabilitate and follow up the child. Now after first phase 1 and phase 2, we can discharge the child and manage in clinic setup during phase 3 management. Here the child is given locally available energy dense foods. You give nutritional advice to the parents, continue mineral and vitamin supplementation, improve hygiene and prevent diarrhea. So now we have come to the end of this lecture. So I hope you have got an idea about what complementary feeding are, what are the foods to be used and foods to be avoided during complementary feeds, the indications to start feeds earlier, then what are the supplementation programs available during the infancy, nutritional requirement during different age groups, and then finally what are the nutrition related disorders which can affect a child.